Hello guys, welcome. So today we are going to deal about the FMG Accelerate, right? So I welcome all the FMG students for this session. Hope you all will like it. And today we are going to take few important PYQs. So in this PYQs we are going to understand what are those important topics which we need to revise before going to the exam. So let us start this session with few important questions. Later on we'll understand what are those important topics and we'll try to understand those important points from those important topics, right? Okay, good evening to all. Abhishek, Salini, Med Psycho, Taufik. So for the first question, at which of the following vertebral level has disc prolapse could have occurred? So now this is the image. So if you can see this image is your MRI, right? So you have various imaging modalities in orthopedics. So first you always start with an X-ray, right? You start with an X-ray. Then for any spine case, if it is related to something like PIVD or lumbar canal stenosis, you go for the second choice of investigations, that is your MRI, right? If it is a trauma, if it is trauma related in case of spine, you go for CT as well as an MRI, right? So these are the imaging modalities which usually the examiner will provide to you in case of spine, right? So in this question, let us understand what is the level at which there is some abnormality here. So here if you can see, there is some which is not continuous, right? There is the spinal canal which is not continuous. So there is a disc prolapse which already the question has claimed. So let us identify the level. I know you're all familiar with this. So you first identify the easiest one. So here the easiest one for me here is your sacrum. So this will become the L1. This will become the S1. So we will try to understand from the sacrum. Then you have your L5, then L4, then L3, then L2, then L1, right? So it has become very easy for us. So the answer here is between L4 and L5, right? So the answer here is L4 and L5. If you remember the spine, so it has C7, right? And then there are 12 thoracic, and then there are lumbar 5 and sacrum 5. Right, so it is made up of cervical, thoracic, lumbar, sacrum, and coccyx. Coccyx is 4. Right, so this is about the spine, and here the level which they have asked is L4 and L5. Right, so this is C8. We have 7 cervical vertebrae. Sorry. Right, 7 8 we have 8 cervical vertebrae, 12 thoracic, 5 lumbar, and 5 sacral, and then you have your coccyx. So this is how your spinal column is presented, and this level here it is L4 and L5, right? And let us understand the root which gets compressed in L4 and L5, right? So if you all remember, let us take the lumbar vertebrae here. So this is L1, L2, L3, L4 and L5, right? And these are your nerves which come from just below the vertebrae. So if you remember, if there is a compression between, for example, L4 and L5, so the nerve which gets compressed is your L5, right? So this is the L5 nerve which gets compressed in this. And similarly, if there is a disc prolapse between L5 and S1, so the S1 nerve root gets compressed. S1 nerve root gets compressed, right? So that is because the L5, whatever this particular, if you think this is L4 and L5, so this is your disc here. So this is your disc here. And whenever there is a disc, there are two important nerves. So one is the exiting nerve and second one is your traversing nerve, right? So the nerve which is traversing will get affected. So because which is passing over the disc. So this traversing nerve which is passing over the disc, because of the disc prolapse, this will get compressed here. So before L4 and L5, the L5 nerve root gets compressed, right? So that is what you have to understand. So that is regarding your first question. So now let's go to the second one. What is the likely deformity of the provided in this image, right? So we have various hand deformities which are seen, and these hand deformities are mainly seen in case of your rheumatoid arthritis. So whenever somebody asks you about this hand deformities, you have to first always remember that the RA is the one such conditions which will provide with various hand deformities, right? So the first one, important one, is your swan neck deformity. Swan neck deformity and the Bottinier's deformity. Swan neck, Bottinier's deformity, and there is again, these are two important which are seen in the fingers, and there is a Z deformity which is seen in fingers again, and there would be a deviation, that is ulnar deviation or radial deviation, depending upon the tendons which get damaged, right? So here if you see what is a swan neck deformity, so what you have to remember for swan neck deformity is this is your swan neck deformity. So what is the swan neck? So whenever somebody says it is swan neck, there is a DIP flexion, right? So DIP flexion, PIP extension is your swan neck. Exactly opposite will be your Bottinier's, where there is a DIP extension and PIP is flexion. So if in this image, if you can see, this is exactly the extension of the DIP and flexion of the PIP. So the answer would be your Bottinier's deformity. So very easy, please remember, first remember the swan neck. So this is exact the shape of the swan neck, where you can see there is a flexion at the DIP, right? So exactly opposite to that, so there will be extension at the DIP, that is your Bottinier's deformity. Then what is your mallet finger? Then what is your Jersey's finger? So this mallet finger and the Jersey finger are a result of the tendon ruptures, right? So mallet finger is nothing but the flexion of the, again, your DIP. This is because of the rupture of the extensor tendon. Rupture of the extensor tendon will cause the flexion, that is called mallet finger. It is usually seen in case of your trauma, right? What is Jersey finger? Jersey finger is exactly opposite. Reverse mallet is your Jersey finger. Jersey finger is nothing but your rupture of the flexor tendon. Rupture of the flexor tendon. So please remember, there are four important deformities which we have discussed: the swan neck, the Bottinier's, and then we have discussed the mallet, and then we have discussed your Jersey finger, right? So sometimes this mallet finger will be associated with the fracture, right? Fracture of the distal phalanx. So you have to confirm this on the X-ray, right? Sometimes there would be only a tendon rupture, right? So this is about the hand deformities. So here the answer would be the Bottinier's deformity. So many of them have answered correct. Now let us go to the next question. Which of the following condition the splint is used for, right? So this the splints which are used are again an important set of questions. So you have to be thorough with what are all the splints used in what are the in whatever conditions, right? So for example, if you see this particular splint in this image, you can see there are two shoes and there is a bar. So this bar is called the abduction bar, and these are your CTEV shoes, right? Yes, very good. The answer is congenital talipes equinovarus. So many of you have answered correct again. So what is this congenital talipes equinovarus? So as the name suggests, it is again a congenital deformity which is seen in the foot, and this can be corrected, 100% corrected, and after 100% correction by your serial casing. So you do this correction by serial casing. So there are various methods which we correct. So what are those two methods? The most important is your Ponseti method. So kite was there, but that is obsolete. Now we are using the Ponseti's method, right? So Ponseti's method we are using, and we are correcting the CTEV. So after this correction, after you have achieved that 100% result of your correction, then you put them in this Dennis Brown splint, right? So this is your Dennis Brown splint, where you place the shoes after the complete correction, and you ask the patient to wear it for 23 hours for 3 months, right? So 23 hours for 3 months, then after 3 months you can shift them to 12 hours. So it is called during sleep, right? 12 hours during sleep you can use them. This is continued again for 6 months, right? All this is done why? To prevent the recurrence. So recurrence rate is high in case of CTV. So to prevent this recurrence, you advise the patient to put them into Dennis Brown splint, where this splint is provided with the abduction bar, and you have this specialized shoes, right, where there is a straight borders and then high toe. And this is because of this position, because of this functional position, the recurrence rate is minimum. So patients are to be encouraged to use this Dennis Brown splint. As I've explained, that is for 3 months they have to use for 23 hours, and then they can shift to 12 hours, right? So this is about your CTEV splint. So then we shall see what is that which is used in DDH. So DDH, what is that splint which we use? It is the Pavlik harness or the von Rosen splint. So these are the two splints which we use in DDH, right? So in case of pediatric orthopedics, we have two important splints. So one is your one is for the DDH, another one is for CTEV. So DDH, please remember, it is the von Rosen splint or the Pavlik harness which we use, and this is also helping the patient to put the limb in abduction. So that is the most safest position to prevent the dislocation. So abduction is the most safest position. So this is done by your Pavlik harness and the von Rosen splint. And similarly in CTEV, you use your CTEV shoes, and then there is a Dennis Brown splint, right? So that is the Dennis Brown splint we are using. How to differentiate between the two? So in case of von Rosen splint or Pavlik harness, you get this strapping. You see this strapping which is present, and these are extended because you have to put the hip into abduction, right? So you see the strapping which is placed over the body surface, and in case of Dennis Brown splint, they are limited only to the foot, because this is the abnormality which is seen in the foot, right? So this splint is seen only in the foot, and if you see the splint which is extending over the body, that is with the help of straps and putting the limbs, that is the hips, into abduction, that is your von Rosen splint, right? So I think that I have answered the query of DK. So now let's move on to the next question. So this is a clinical scenario. A young man fell from 12 feet height, presented with the right-sided limb, and a right leg was abducted. On examination, right lower limb was short, and he was unable to abduct his right lower limb, which is the nerve injured in this patient. So here there is a clinical scenario where you see there is a patient who is falling from 12 feet height, and he has presented with the right-sided limb and right leg was abducted, right? And on examination, right lower limb was short and he was unable to abduct his right lower limb, which nerve is injured in this patient. So let us see various conditions where there is an injury to the hip joint, and what are those positions where the hip joint is presented, right? Okay. Now let us see the most important one is your posterior dislocation of hip. So whenever there is a question on posterior dislocation of the hip, it is always starting with trauma, because there should be a huge high velocity trauma which will force the limb into a specific flexion, adduction and internal rotation position, right? So farther position whenever is seen, and that too associated with the trauma, this is nothing but your posterior dislocation of hip, right? That is clear. And then if the patient is again presenting with trauma, and this time if it is the flexion, abduction and internal rotation, this could be an anterior dislocation, and usually this is seen in young individuals, right? And this dislocations will depend on the patient's positions. Okay, and one more thing which you have to remember is the flexion, abduction and external rotation. This is also seen in case of your IC fracture and IT fracture. But in this cases, external rotation is the one which is more important than the flexion component. So external rotation, that is more pronounced in case of the IT fracture and less pronounced in case of your IC fracture, because this is covered with the capsule. Now because of the presence of this capsule around the hip joint, it will prevent the amount of external rotation which is seen more in case of extracapsular, that is your intertrochanteric fracture. So if somebody is putting the age as somewhere above more than 50 years, and now on the now in casualty, if you see there is an external rotation of the limb, and if this limb is completely touching the couch, and then that is your IT fracture. Right, so with external rotation, if your limb is completely touching the couch like this is the IT fracture. If there is only minimal external rotation, if somewhere it is between like this, then that is your IC fracture. If there is a classical deformity of flexion, abduction and external rotation, and a young patient with the trauma, and if there is now here in this case, there is asking what is the nerve injured in this patient. So here the leg is adducted, right? So it is in adduction, and adduction is in favor of the posterior dislocation. And whenever there is a posterior dislocation of hip, what is the most common nerve which is injured is your sciatic nerve, right? So this is the sciatic nerve. The answer is the sciatic nerve, right? In case of posterior dislocation of the hip, what is the most common nerve which is injured? It is sciatic nerve. So that answers this question. And now let's move on to the next question. A 29-year-old man presented with left leg pain after road traffic accident. On examination, tenderness was present on the left shin. Right, an X-ray of the left leg shows tibial diaphyseal fracture. So here we have the fracture, that is tibial diaphysis. He initially responded to analgesia, but now complains of increasing pain and tightness in the left leg. Which of the factors indicate the worst prognosis? Right, so if you read the entire question, I'm pretty sure that you all have already answered in your mind, and you already know what is the topic which we are dealing here. The most important topic, that is the compartment syndrome. So here this topic is very, very important, and you have to pay a keen attention while discussing this topic, because now the question is about the factor which is producing the worst prognosis, but there could be some other questions which can be asked. So let us discuss about the compartment syndrome. So you all already know that the limbs and the muscles which are present in the body are placed in the compartments. So there are various compartments. And for example, if you take the leg, where the compartment syndrome is most common, that is the anterior compartment is the one which is the most common compartment which goes into compartment syndrome, right? So first thing what you have to remember here is the anterior compartment, right? What are the muscles of the anterior compartment? All the extensors muscle, that is the tibialis anterior, your extensor hallucis longus, and peroneus tertius, extensor digitorum longus. So all these form the anterior compartment, right? And the lateral compartment is your peroneus muscles. The posterior compartment has two, superficial and the deep. So the superficial is gastrocnemius and the soleus, and the deep compartment or your flexus, right? So this is how you have to remember the compartments which are present around the leg especially, and the most common one would be your anterior compartment which goes into compartment syndrome. And again the next question will be, what are the various causes where the compartment goes into compartment syndrome? The first and the foremost and the most important one is nothing but your trauma, and that trauma is your tibial fracture. So whenever you see a patient with tibial fracture, that too a closed tibial fracture, you have to always be suspicious about compartment syndrome, right? So what actually is this compartment syndrome? So when you know that there is a compartment which is a closed one, so why it is very closed? Because of a tight structure which is called the fascia. So these muscles are arranged in this compartment divided by this fascia. So here in this compartment, if you see, which is enclosed by the fascia, so there are muscles which are present inside it, right? Now there has been trauma which has been occurred to this compartment. So there is a trauma, and because of this trauma there is some damage to the muscle, and now because of this damage there will be a pressure gradient difference. So usually if you see, the blood flows along the pressure gradients, right? So whenever there is compartment syndrome, that means there is an increase in the pressure of the compartment. So this increase in the pressure of the compartment will further decrease the arterial blood flow. So whenever there is a decrease in the arterial blood flow, there will be ischemia of the muscles. So this ischemia will again produce the edema, and this edema will again increase the pressure. Again there will be a cycle. So this is the important cycle which you have to remember in case of compartment syndrome. And because of this vicious cycle which is happening in this closed compartment, these muscles are prone to the injury. And whenever this is happening, the patient presents with 5 classical signs and symptoms. That first one is pain, and that is the stretch pain, right? So there will be pain, there will be pallor, and there will be paresthesias, right, because of the compression of the nerve in the compartment. And then there will be paralysis of the muscle, and then there will be the pulselessness, right? So these are the 5 classical syndromes, 5 classical signs and symptoms which are called as the 5 P's of the compartment syndrome, right? And here the pulselessness and the paralysis, everything will occur at the later stage. But what is the most important for us here? The most important thing is your pain. So pain is the one which is most important, and always remember that the compartment syndrome is a clinical diagnosis. So there are no tests which are very classical for this, but this is mainly the clinical diagnosis which you have to do. And what is that pressure? The pressure will be more than 30 mmHg. If the pressure is more than 30 mmHg, you confirm this as compartment syndrome, right? And what is the this is a surgical emergency, as I've already told you, and we already know the pathology is all because of this tight structure called fascia, and the treatment will be the fasciotomy of the compartment. And once you see the anterior compartment syndrome, you have to always examine for the other compartments too. So then the fasciotomy should be done, and this is done under emergency. And once it is done, the pressures are relieved, and then the muscle can be rescued. So here the worst prognosis will always be the paralysis. So pulselessness can sometimes lead to, if neglected compartment syndrome, the muscles can go to complete contractures, right? Complete contractures. And if you remember, the dreadful complication of your compartment syndrome is the VIC. VIC is Volkmann's ischemic contracture, which is seen in case of your forearm muscles. Forearm muscles will present with this Volkmann's ischemic contractures. And here, if you see the worst prognosis, which of the factors which indicate the worst prognosis is the paralysis. So once the muscle have entered the paralysis, or if they are completely damaged, they could not be rescued. So that is the worst prognosis which can be seen. And sometimes the pulselessness, if the complete absence of the pulse, which might result in gangrene also, right? So here, according to this question, the paralysis would be the answer. And sometimes the pulselessness is the late presentation, and you should not wait till the pulses are absent. You have to immediately respond, and clinically you have to diagnose and take the patient to the fasciotomy for relieving of all these classical signs and symptoms, right? So that is about your compartment syndrome. So now let's go to the next question. A 35-year-old man presents to OPD with a wrist drop. So here there is a wrist drop. He had a heavy drink a day before and slept in the chair for a whole night. Physical examination revealed a diagnosis of radial nerve injury. What kind of injury has occurred? So here if you see, there is the clue which is given is your radial nerve injury. Radial nerve injury, and nerve injuries are one of the most important topics in all exams, right? Even if you take your NEET PG, your FMGE, your INICET, every exam will have this question on the nerve injuries. So this is one of the important topic which you have to always be thorough for answering the questions from the orthopedics. So here if you take up nerve injuries, you already know that there are three important types. So the first one is your neuropraxia, the second one is your axonotmesis, and the third one is your neurotemesis. Right, so the neuropraxia, axonotmesis and neurotemesis. Coming to the neuropraxia, this is just a block in the conduction. So block in the flow or the block in the conduction of the axoplasm of the nerve. So if you remember, the the structure of the nerve, it consists of the cell body followed by the axon, and then you have dendrites, right? So first there will be the dendrites, then the cell body, right? This continues as the axon, and then you have your axon terminals, right? So here the axoplasm flows in the axon. So this flow is obstructed, or there is a block to this axoplasm flow. So whenever there is a block in this flow, there is no signals which are passed from nerve to nerve, right? So there is a block in the conduction. So that type of injury is called the neuropraxia, and because here there is an intact of complete nerve, so there is no damage as such, structural damage which is present to the nerve. Because the entire structure of the nerve is intact, there is a chance of recovery. So this recovery is always 100% in case of neuropraxia, because the entire structure of the nerve is intact in case of neuropraxia, and there is only flow block which is seen, right? The classical example of this neuropraxia is your Saturday night palsy. So example of neuropraxia is Saturday night palsy, where the patient will have binge drinking and will cause compression of the axilla, where your radial nerve gets compressed because of the posture. This is because of the posture, and this radial nerve, whenever it gets compressed, it gets damaged, and this results in the classical wrist drop. So whenever you see a sudden onset of the wrist drop, there is a sudden onset of the wrist drop because of the binge drinking which the patient had, this is called as the Saturday nerve palsy. And this because completely the nerve is intact, and then the recovery is always 100% in case of neuropraxia. So for as the nerve is injured, now you have to protect the tendons, because the nerve is not giving this nerve is not giving the stimulation to the tendons. These tendons may land up in the contractures, so you have to make these tendons work. And how do you make them work? You put them in splint in the functional position. So whenever you put them in functional positions, you make the tendons to work, or you put the tendons in the functional position. So by the time the recovery is happened, so how the recovery happens? So again there will be a reflow of the axoplasm, and this flow is termed as 1 mm per day. 1 mm per day flow will start, and once this flow is progressing, you can see that the wrist drop has reversed, right? So when the nerve is working, you have to now make the tendons ready to work, right? So for that you use the splint, and this is a classical example. As we have already discussed, the answer would be the neuropraxia. So in case of Saturday night palsy, whenever there is a radial nerve injury, you always answer that is as a neuropraxia, because there is no structural injury to it. But for example, if the same patient has some cut over the radial nerve, and now he have presented with a wrist drop, and because there is a damage to the axon here, so there will be a damage to the sheath or axon, and here this is called as axonotmesis. And in neurotemesis there will be complete cut or complete damage to all the layers of the nerve. So all the nerve layers, so if you remember the nerve layers, so first it is the nerve fiber which is surrounded by the endoneurium, and these are arranged in case of fascicles, right? So these fascicles are covered by the perineurium, and all such these fascicles, now they are covered by the epineurium, right? So there is endo, there is perineurium, and then there is epineurium. So when there is complete transaction of all these layers, it is called the neurotemesis. So whenever there is only damage to the axon sheath or the axon as such, it is called the neurotemesis. So because there is still an intact nerve layers, because there is only damage to the axon, still there is epi and the perineurium which are still intact, the neurotemesis, the recovery could be somewhere around 80%, right? So you can still see the recovery, but neurotemesis, no chance of recovery, and the patient should always land up with the nerve repair or the tendon transfers. So whenever the nerve is at damage, you go for repair of that nerve, or ultimately you go for what is called as the tendon transfers. But here if you see the axonotemesis, the recovery will never be 100%, but for neuropraxia you can claim it to be 100% recovery. So this is one of the important topic, and these are few important nerve injuries which you can expect in your exam, right? So this is about the nerve injuries. Let's go to the next question, that is a 49-year-old diabetic patient has the following X-ray findings. What is the diagnosis? So as soon as you see this immediate clinch, that is the diabetic patient, you have to always think one type of joint in your head, that is your Charcot's or the neuropathic joint. Charcot's or neuropathic joint. So what are these Charcot's or neuropathic joint? So here, because of the diabetes, because of the nerve injury that has happened, so this nerve, the sensation such as the pain is absolutely decreased. So there will be a complete loss of pain sensation to the patient, right? So whenever there is absence of this pain sensation, the patient may land up with lot of minimal trauma, right? Minute trauma, whatever the trauma is there, the patient will not appreciate, and this might result in formation of ulcers and ultimately the gangrene. And here in case of your bones can be completely get osteoporosis. So there you will see there is a lot of damage which is not in proportion with the patient's history. So damage is always more when you take the history from the patient. So this disproportionate of the history and the imaging is always seen in case of the neuropathic joint. So what is a neuropathic joint? Where the patient will not have any sensation. So because of this loss of sensation such as pain, the touch, so there will be a lot of minor injuries which is happening to the patient, and because of that there will be a lot of bone changes. If you see, there is there will also be fracture to that particular bone, and still the patient will not complain of pain. And because there is no pain, he keeps walking on the joint. So here there will be a lot of amount of sclerosis, there will be osteoporosis, and the amount of damage will be disproportionate to his history. So one such joint which you see here is called the Charcot's joint. So Charcot's joint is nothing but a finding which is seen in patients who presents with first the chronic diabetic patients where the sugar control is very poor. So because of this poor sugar control, the neuropathic the nerve endings will get damaged. So because of this nerve endings are damaged, the patient will not experience any pain, and there will be loss of sensation such as pricking sensation. So he will step on various sharp objects, and then there will be trauma. The patient will be unaware of this. Sometimes they may also land up with fractures, and these fractures they end up with non-healing again, and this patient will not even have pain, right? He will not even have pain, but he keeps walking on that limb. And now when you take the x-ray, the damage which you see on the x-ray is much more than the history. So that type of joints is called the Charcot's joint. So as we have discussed about these joints, let us see what are the other type of x-ray findings. So in case of these joints, mainly you have to understand between the degenerative, that is your osteoarthritis, and then there is an inflammatory arthritis, right? So that is your rheumatoid arthritis. So you have to be able to differentiate between your osteo and your rheumatoid arthritis. In case of osteoarthritis, there are three classical findings. So first one is your joint space narrowing. So first classical finding is joint space narrowing. Then you will have your osteophytes, and then there will be sclerosis. So these three are the important signs which you see in your osteoarthritis patient x-ray, right? And in case of rheumatoid arthritis, the most important thing, it is bilateral, it is symmetrical. So bilateral and it is symmetrical, and mostly you see these findings in case of hand, right? And there will be a juxta-articular osteoporosis. Juxta-articular osteoporosis, and you will see there are joint erosions. So these are a few findings which you see. And even in your inflammatory also, there will be a joint space narrowing, and again this narrowing can be bilateral, which you can see on both the medial compartment and the lateral compartment, right? But in case of rheumatoid, this is mainly seen in the medial compartment. So why medial compartment? Because that is the weight bearing axis. So if you see, the weight bearing axis will go through your medial compartment in case of your knee joint. So because this degeneration is wear and tear mechanism, so here the medial compartment will get damaged. And in case of inflammation, this is a antigen antibody reaction which is occurring. So it can occur in the medial or the lateral compartment. So you see a bilateral joint space narrowing, and you can even see in the right and left knees together. And then the classical symptom, classical sign which you have to see is the juxta-articular osteoporosis, and then there will be joint erosions, right? But in case of osteoarthritis, you will see sclerosis and osteophytes, right? So that is how you have to differentiate between the inflammatory arthritis and the degenerative arthritis, right? So here so here you don't see any joint spaces which is involved. So joints are not involved. Here classically you see there is a trauma to the calcaneum, and here the calcaneum has been eaten up. So this is the ankle joint is one such the classical example for your Charcot's joint. So ankle and the foot. So usually ankle and the foot, because I have already told you so much about the Charcot's, because the nerve have been damaged, the peripheral nerves and the end nerves have been damaged. So usually patient puts weight. So the ankle and the foot are one which are mainly involved in the Charcot's joint. And if it is osteomyelitis, what will you see? The classical signs of osteomyelitis on case of X-ray, the one important thing which you see is your sequestrum. That is in case of your chronic osteomyelitis. So how is the sequestrum present? So this is a dense bone which is surrounded by a layer of sclerosis, right? A dense bone which is surrounded by a layer of lucency. Why it is a dense bone? Because there is no blood supply to this particular part. So whenever there is no blood supply, there will be no removal of the calcium, right? So there is no activity, there is no osteoclastic resorption which is present in the normal bone. So that is why this sequestrum appears dense on the X-rays, which is surrounded by a lucency, right? So then you can see a sequestrum, then you see involucrum, which is again a new bone formation in case of chronic osteomyelitis. And sometimes you can see what are called the cloaca, the opening for the sequestrum to drain, right? So these are the classical chronic osteomyelitis X-ray findings which you see on the X-ray. And here if you see, there is a destruction of the bone. So this bony destruction will usually tells you about the Charcot joint, right? So that is about the joint and their X-ray findings. Fine. Now we are going to the next question. The patient with the RTA had a fractured shaft of humerus. After injury, he was unable to dorsiflex the wrist. He was advised a splint. Identify this splint. So in this case, if you see, there is a fractured shaft of femur. So there is a shaft of femur fracture, and now the patient is unable to dorsiflex the wrist. So these two are the important clues which you have to take up. And whenever there is a shaft humerus fracture, you already know that there is a radial groove. There is a radial groove which is present on the posterior aspect of the humerus, and this radial groove will contain the important nerve that is called the radial nerve. So whenever there is a damage to this radial nerve, there will be a wrist drop, that is nothing but the unable to dorsiflex the wrist. So what is the action of the wrist joint? It will cause the extension. So it is important for the extension of the wrist and extension of the fingers. So here the patient is unable to dorsiflex the wrist. That means he is presenting with wrist drop. So this shaft humerus with wrist drop is very classical, right? And this is called the Holston-Lewis fracture. So here this is exactly at the junction of the middle third and the distal third, right? Here, because of the tethering of the nerve, so here because of this tethering of the nerve, that is, nerve is attached to the bone and it cannot move. So whenever there is a fracture, it gets crushed between the fracture fragments. That is exactly between the junction of the middle third and the distal third. So if you remember, you can divide the humerus into proximal third, middle and distal, right? So this junction of middle and the distal third, you see this radial nerve which is crossing over, and then because of this fracture, because if it is attachment to that particular part, attachment to the humerus bone, which is usually immobile because of this attachment, right? And whenever there is a fracture, this nerve gets crushed in between, and now this will present with wrist drop. So what is this splint which you use for preventing the tendons to enter into contractures, right? We have already discussed why we are using splints. So splints are used to put these tendons to a functional position. So here the wrist drop is treated with which splint? So that is the cock-up splint. So this cock-up splint is of two types, the static and the dynamic cock-up splint. So static is you just put them in the functional position, and dynamic cock-up splint is you put the tendons to work, that because of the springs which are attached, you can extend and flex the fingers. So that is the dynamic cock-up splint. So the answer here is the cock-up splint. Right, now let us see the other splints also. So here the aeroplane splint. So aeroplane splint is used for your brachial plexus injury. Brachial plexus injury, where you put the shoulder in abduction and elbow in flexion. So this is your aeroplane splint. And then the knuckle blender splint. The knuckle bender splint is used for your ulnar nerve palsy. So ulnar nerve palsy is a knuckle bender splint, aeroplane splint for brachial plexus injury, and cock-up splint for radial nerve injury. And you have one more in the option, that is the Thomas splint. So this is important again. So what is a Thomas splint? So Thomas splint, if you remember, it is with the outer ring. So there is one ring, and then you have your bars, that is outer bar and the inner bar, where the outer bar has this extension, right? This outer bar is having, so it can accommodate the greater trochanter here. So this is for outer and this is for the inner, and now these two are connected with W-shaped structure. And this is your Thomas splint. Here they make an angle of 120 degrees. So this is your Thomas splint. So where do you use this Thomas splint? So Thomas splint is mainly used for fracture shaft of femur, and this is a type of the fixed traction which it provides, and there will be a layering which you have to do. And this, after this layering, you wrap the limb in this Thomas splint, and mainly you use the splint for immobilization of the part and mobilization of the patient, right? So you can mobilize the patient without pain by putting this limb into this Thomas splint, right? So mainly it is used for fracture shaft of femur, but this Thomas splint was invented by the Thomas during World War II for treatment for skeletal tuberculosis. So whenever there is a knee tuberculosis patient have been treated with this Thomas splint, but now we use them for fracture shaft femur. So aeroplane splint is for your brachial plexus palsy, and then your Thomas splint you have already learned in a great detail, and knuckle blender splint is for your ulnar nerve palsy, and then we are left over with the cock-up splint, which is for the radial nerve palsy, right? So that is about the splints. Which nerve is involved in this deformity? So this is a classical deformity, and the classical photograph which is usually presented in case of X-ray, in case of your image based questions, that is your IBQ. So here if you see, there is a deformity in the little and the ring finger, right? So this is what is that deformity you see? There is a extension of metacarpophalangeal joint, and there is a flexion of your interphalangeal joint. So this is the deformity which you're seeing, right? And this deformity is called the classical ulnar claw deformity, right? So this is your ulnar claw deformity which is seen, and this ulnar claw, if you remember, is because of your ulnar nerve. So why ulnar nerve? Because ulnar nerve supplies all the intrinsic muscles of the hand, and one such intrinsic muscles are the lumbricals. So here the lumbricals get damaged, and this is called reverse of lumbricals. So usually lumbricals help for the flexion of MCP and the extension of IP. So there is a reversal of this action of the lumbricals which is called as ulnar claw. So this is a partial clawing. So this is an example for a partial claw hand, and this is ulnar nerve palsy, ulnar nerve palsy, right? And whenever there is a complete claw hand is when there is ulnar and a median nerve together. So that is your complete claw hand, right? So here it is only partial. Partial means the ring and the little finger. So the answer is your ulnar nerve, right? So this is a classical IBQ, and I hope nobody should mark wrong for this answer. So this is the ulnar nerve, right? So if you remember the ulnar nerve muscles which are supplied, ulnar nerve will supply the third and the fourth lumbricals as we've discussed, and it will supply the palmar interossei muscles, and then the dorsal interossei muscle, and then it will supply your hypothenar muscles. And the most important thing you have to remember is your adductor pollicis. So this is a adductor pollicis is what? It is a thenar group of muscles. So whenever there is a word called pollicis, that means your thumb, right? So this pollicis is thumb, and adductor pollicis is supplied by the ulnar nerve, right? So here will come your Frohman sign, here will come your card test. So signs, what are the various tests where the ulnar nerve is tested? So that is, first one is your card test. So card test, you test what? You test the adduction, right? And then you have your Igawa test, and then you have your book test. But book test is mainly for your median nerve. So book test, what you do, you ask the patient to hold the book, and whenever there is a paralysis of this ulnar nerve, the adductor pollicis is damaged, and here you see the flexor of the flexion of the thumb. So this is done by the flexion of the thumb, and that is where your median nerve is intact, and there is the ulnar nerve palsy, mainly to test that important muscle, that is your adductor pollicis. So that is the again the base for your Frohman sign. So what is your Frohman sign? Froment sign is again flexion of the thumb. IP joint of the thumb is getting flexed. That is your Froment sign positive. So whenever there is a Froment sign positive, this is because of the intact median nerve. And adductor pollicis is has been damaged. That is because of the ulnar nerve palsy, and that is the basis for your book test. Right. So that is about the ulnar nerve. Now let's go to the next question. A 27-year-old patient was diagnosed with supraspinatus tendinitis. What degrees and what movements of the shoulder would be painful? So this is a classical, again a question on the rotator cuff of the shoulder joint. So rotator cuff is again an important topic. So rotator cuff in case of the shoulder joint. So rotator cuff are the sit muscles, right? What is the sit muscle? So first is the supraspinatus, and then you have your infraspinatus, and then there is teres minor, and then there is your subscapularis. So these are the four rotator cuff muscles which are present around the shoulder, right? And if you remember, the subscapularis is present on the anterior aspect of the shoulder joint, and these are present at the superior, that is the supraspinatus, and these are infra and teres are present on the posterior aspect. So that is how they covered the entire shoulder joint, right? Under the deltoid cuff, so there is a deltoid which is present, the deltoid muscle. Under this you have your rotator cuff muscles, right? And the most important one here is, according to the question, is your supraspinatus. So what does the supraspinatus do? It is mainly involved in abduction along with your deltoid. So deltoid is the muscle which is mainly responsible for abduction, but this initiation of the abduction is by the supraspinatus. So what is this initiation? So the 0 to 15 degrees of the shoulder abduction is by your supraspinatus muscle. So now once you want to initiate the abduction movement, so if you remember, your shoulder joint is one of that important and the most mobile with highest freedom, right? So there are various movements which can occur in the shoulder joint: the flexion, the extension, the internal rotation, the external rotation, the circumduction, the adduction, the abduction. So these are all the movements which are occurring here. So there are various muscles which help in this movement. So one such important action of the shoulder joint is abduction. So this abduction is initiated by the supraspinatus muscle, and the overhead abduction again assisted by the trapezius muscle, right? And this deltoid is very important muscle for the abduction. The entire range of abduction is by deltoid, but it is the starting 0 to 15 is by your supraspinatus. This you have to remember. So whenever there is a pain after this 0 to 15 degrees of the abduction movement, then this might be because of your supraspinatus tendinitis. So we have already given a clue in the question, that is your supraspinatus tendinitis, and we already know that the supraspinatus is for abduction, and that too specifically for your 0 to 15 degrees of abduction. And you have to remember the supraspinatus will initiate. So that is how you remember that it is from 0 to 15 degrees. So that is the answer for this question. And this abduction movement will be painful in case of supraspinatus tendinitis. Okay. So that is about the rotator cuff. And now let's go to the next question. The person sitting in the front seat of the car met with a road traffic accident following his injury. His lower limb was in flexion, adduction and internal rotation. So what is the diagnosis? So whenever you see something like this without even the x-ray, the flexion, adduction and internal rotation, that is farther, and we already told you that a patient will sit in the car that is high velocity and met with a road traffic accident, right? So this we need not even see the x-ray, and you can straight away answer this as your posterior dislocation of hip. So we already know that the posterior dislocation of the hip is a result whenever there is a dislocation, the hip joint goes into flexion, adduction and the internal rotation, right? So that is the answer for the posterior dislocation of hip joint, right? So here let us discuss little about the posterior dislocation, because that is also one of the important topic. And whenever there is a posterior dislocation of the hip joint, this is mainly because of the what mechanism of the injury? It is mainly seen in the car, and it is the dashboard injury. So dashboard injury complex, which we are going to learn. So first in this is your posterior dislocation of hip joint because of the flexion position of the hip and the knee, right? So because of this position of the limb and injury occurring to it, this results in the posterior dislocation of the hip. So the next one would be your patellar fracture. So this patellar fracture will be as a result of the direct injury to the patella, and then there will be PCL injury. So PCL is the posterior cruciate ligament injury, and this completes the dashboard injury complex. So whenever you have a patient with a history of a car travel with the high velocity injury and there is a posterior dislocation, you have to always examine the knee joint for patella fracture, and you have to examine for any ligamentous and specifically for your PCL injury, so posterior cruciate ligament complex, right? So this is your posterior cruciate ligament injury. So one of the example for the dashboard. And then in the case of posterior dislocation, the common nerve is already we have discussed the sciatic nerve, and I need not mention that this results in father, which is very, very important, right? And this dislocation is an emergency, and you have to always reduce. And there is a maneuvers like various names have given for this maneuver, such as Alice maneuver. So these maneuvers have been done and you have to reduce it, and usually we do the dislocation reduction under anesthesia, and soon it is reduced, you put them to traction. So you can apply a skeletal traction. So here this will put the hip in the functional position. So you immobilize the hip with 3 weeks of skeletal traction after reduction, and you always check for the other important fractures, right? So this dislocation can be associated with a fracture, so this could be a fracture dislocation. So you have to always examine the patient thoroughly, right? And then you already know that there is anterior dislocation where there is a fiber, and then there is a central dislocation. So there are 3 types of dislocation. The most common one is your posterior, then there is anterior, and the central. Central is always inevitably associated with the fracture. So this is always a fracture dislocation, and it is the acetabulum or the pelvis fracture which we usually see, right? And in case of anterior dislocation, the classical presentation will be fiber, that is flexion, abduction, and external rotation, right? So this is little about the dislocation of the hip, and there will always be a question on the hip dislocation, which is very important. So we have already dealt 3 important topics, so you have to always thoroughly revise your nerve injuries, then the dislocation topic, right? So these 2 are very, very important. And about the nerve injuries, you have to revise the tests and also the splints which we use for nerve injuries, right? And now we are going to the one more important topic, that is the metabolic disorders. So in case of metabolic disorders, let us first answer this question and let us go into this topic. So a 70-year-old male presented with, so the age factor is very, very important, with multiple bone pains, there is anemia, there is a renal failure, there is proteinuria and hypercalcemia. X-ray is shown below. What is the diagnosis? So here if you see the X-ray, this is the X-ray of the skull, and you can see numerous punched out lesions, right? So classical example of punched out lesion in case of the skull bone, and then when they were associated with the proteinuria, that is the Benjon's protein, and then there is hypercalcemia. All this lead to one important condition, that is your multiple myeloma. So what is this multiple myeloma? So multiple myeloma is a most common tumor That is your hematopoietic tumor seen in case of orthopedic oncology. So this is the most common tumor. So here you see this is mainly in the elderly age group, that is above 60, 70, 80. And here the dysfunction of the plasma cells, and there is increased production of the proteins. This will result in the proteinuria, and these proteins are the classical Jones proteins. And multiple myeloma, because of the resorption, it is associated with the hypercalcemia and the pancytopenia, where you see decrease in the red blood cell. That is why you have your anemia, right? And then you have decreased in the platelets, decrease in the WBC, and that is why people are prone more for infections, right? So these are the classical symptoms of the multiple myeloma, right? So whenever there is hypercalcemia, you have associated hypercalcemic signs, right? So whenever there will be a constipation which is seen, and you will have bone pains like psychic moans, and all this because of the hypercalcemia, right? So these are all the presentations for multiple myelomas. And multiple myeloma, the classical thing which you see is the proteinuria, and these proteins are the Jones proteins. So immunoglobulins are decreased, and there will be excessive formation of the defective immunoglobulins, right? So this is about the multiple myeloma. So this is multiple myeloma, where you see a punched out lesions in case of the skull, and this can also be described as moth-eaten appearance. Punched out lesions or moth-eaten appearance in case of multiple myeloma. So what is hyperparathyroidism? So hyperparathyroidism is a condition where there will be an increase in parathormone hormone, and this parathormone is important for increasing your calcium, right? So because of this increase in calcium, again you will have all the symptoms of your hypercalcemia. So this increase in the parathormone itself, or because of the parathyroid, is called the primary, and because as a effect of any other condition such as the renal conditions, the kidney has failed to balance the calcium, and whenever the calcium is low, there will be an increase in the parathormone. This will result in what is called a secondary parathyroidism. This is because of the parathyroid glands themselves. So primary is because of the parathyroid glands, because adenoma, the hyperplasia, the hypertrophy, and then the secondary because of the kidney failure. And one more interesting one is your tertiary, where the patient will be in a prolonged hyperparathyroidism, that is tertiary, and because of that, because of the kidney failure mainly, and end stage renal disease, where the patient might present with transplantation, and because of the prolonged condition of this hyperparathyroidism, the parathyroids will go to hyperplasia, and because of this they produce parathormone. This is called tertiary, where the patient is treated, and then they will, because of the reactive hyperplasia of the parathyroid glands, they will produce increased parathormone. This is called the tertiary. So you have to differentiate between the primary, secondary, and tertiary. This is done based upon the history, but the classical thing, whenever there is an increase in parathyroid hormone, is there will be increase in calcium. So this increase in calcium is seen on the x-rays. So classical signs of hyperparathyroidism you can see on the x-rays, right? So this increase in the calcium is by the osteoclastic resorption, right? So this resorption is seen around the phalanges in case of parathyroidism. So that is the classical resorption of the phalanges. So in case of hand, you see the x-rays, there will be osteoclastic resorption of the phalanges. So that is the parathyroid, and here you have multiple myeloma, right? So, and what is this carcinoma prostate? So let us discuss little of the carcinoma prostate. Why? Because there is again hypercalcemia which can occur because of the tumor. So tumor metastasis is one more important conditions which you have to remember in orthopedics, and here specifically for prostate, what you have to remember is the metastasis or here or the osteoblastic in case of your prostate cancer, right? And in case of your breast, they are osteolytic. So that is how your prostate cancer is related to orthopedics, where you have your osteoblastic deposits, and these deposits are typically seen in the vertebrae and mainly the dorsal vertebrae. So here the metastasis is most important condition of orthopedics is metastasis, right? Secondaries are the most important and most common one. After secondaries, the most important primary is your multiple myeloma, right? So in case of secondaries, you mainly see them in case of vertebra. That vertebra is mainly the dorsal vertebrae. And here what you have to remember about the prostate cancer is these secondaries are osteoblastic, and in case of breast there are osteolytic. So that completes the answer for this particular question. Let's go to the next one. Identify the marked bone in the given image. So this is somewhat related to the anatomy part also. So this could be an integrated question. So where they have mixed with orthopedics. So here you have to name them. So here first, these are the metatarsals. So first metatarsal, the second, the third, the fourth and the fifth. So these are the phalanges. Now let us name the tarsal bones, right? So here you have the cuneiforms. So there is a medial cuneiform, the lateral and the intermediate cuneiform. Then you have the second row, that is your cuboid and the navicular. And then you have your calcaneum and the talus. So if you remember, the ankle joint is formed between tibia and the talus, and the subtalar joint is formed between talus and the calcaneum. So talus and the calcaneum will form your hind foot, cuboid and navicular your mid, and this is your forefoot. So here now let us identify here. So here there is talus, which is forming the ankle joint, and you can see some amount of calcaneum here, and then there is this navicular. So this is your navicular, right? So this is your cuboid, and these are your cuneiform, the medial cuneiform, the intermediate and the lateral cuneiforms. So these smaller bones are nothing but your cuneiforms. So this middle one is your navicular bone, and this one, the rare one, is your talus, which is little white in color, and then this is cuboid. So this is your cuboid. So here they form the calcaneocuboid, and then with the talus it will form the talonavicular. So if you want to identify, there is the joint, the talonavicular, and then there is calcaneocuboid, right? So this talonavicular is present on the medial side and the calcaneocuboid on the lateral side, and side of this cuboid you will see the cuneiform. So these are the cuneiforms. So this navicular bone, which is shaped again, this is your navicular bone, right? So this is a straightforward question. So that is your navicular bone. That is about the tarsal bones. Okay, now let us go to the next question. Which of the following artery is palpated behind the medial malleolus? So this is again an anatomy question. So you have to be thorough with the various vessels and the nerves of the compartments. And if you see, this is behind the medial malleolus. So behind the medial malleolus is nothing but your posterior compartment. So what is the artery of the posterior compartment here? So it is your posterior tibial artery, and anterior tibial is present in the anterior compartment, right? So the continuation of your anterior tibial is your dorsalis pedis. So your anterior tibial artery will continue as a dorsalis pedis in case of foot, and on the posterior aspect you will have your popliteal in case of knee joint. So this popliteal artery is present in the knee joint, which divides into tibial arteries. So here in case of your medial malleolus, so behind this medial malleolus on the medial aspect, you see there is the posterior tibial artery, right? So this artery is present in association with the three important tendons, which you remember as Tom, Dick and Harry. So here Tom, Dick and nervous Harry, right? So this is about the arrangement of the structures behind the medial malleolus. Tom is for tibialis, D is for digitalis, this is the hallucis. So you will have Tom, that is your tibialis posterior tendon, then you have digitorium, and then you have artery, then the nerve, and then you have your Harry, that is your hallucis. So this is how the structures are arranged behind the medial malleolus. So do you remember them as Tom, Dick and a nervous Harry, right? So that is the posterior tibial artery associated with the posterior tibial nerve in the posterior compartment behind the medial malleolus, right? So now let's go to the next question. Which of the following is the most radiosensitive tumor? So here you have to have this one-liner knowledge, and you have to straight away mark this as Ewing's sarcoma. So Ewing's sarcoma is considered as the most radiosensitive tumor, which just melts like a snow. So classically, the Ewing sarcoma, when it is subjected to radiation, will melt like a snow, which is called the radiosensitivity is highest in that particular tumor. So that is the Ewing sarcoma. But please mind that the radiotherapy is not a modality or the treatment of choice in case of Ewing's sarcoma. But the most radiosensitive tumor is Ewing's sarcoma. Okay, that is the 16th question. Now let us see again image based question. So here you have to identify this splint. So before identifying this splint, let us understand little bit of the orthosis. So what is an orthosis? So orthosis is a part or a product where it supports the body, right? So here, depending upon this support which is given to that particular part of the body, it is named as the cervical orthosis, thoracic, lumbar orthosis, or your sacral orthosis. So based upon the support which they provide to the body part, they can be named as the accordingly to that particular part. So for example, if it is supporting the cervix, it is called the cervical orthosis. If it is supporting the thorax, it is called the thoracic orthosis. So if it is supplying the entire one, if it is supporting the entire spine, it is called the cervical, thoracic, lumbar, sacral orthosis, that is CTLSO. Right? So if it is supporting the ankle joint, it is called the ankle orthosis. So what is the foot drop splint is an example for your ankle arthrosis, right? So here if you see, this is supporting the thorax, right? So here it is supporting the thoracic vertebra and the lumbar vertebra. So this is your thoracolumbar orthosis. Thoracolumbar orthosis, and in short form it is called your Taylor's brace splint, right? You will call this as your Taylor's brace. So what is this Taylor's brace? So this is the splint which supports the spine and especially the thoracic and the lumbar spine. And where do you use them? The most classical thing where we use is the TB spine and then vertebral fractures, right? So vertebral fractures, TB spine are the areas where you support the spine, right? So these are the areas where you use the splint. This is called the Taylor splint. And now you already know what is von Rosen splint, that is for the DDH. And scoliosis. So what is a scoliosis? The scoliosis is nothing but the curvature which is present in spine. So there is a sideward curvature, right? So there will be a sideward bending of the spine. So whenever there is a structural scoliosis, you need to support this, or you need to correct this deformity. So if it is the scoliosis is calculated based upon the angle, right? So what is that important angle? It is called the Cobb's angle. So you measure the Cobb's angle, and if it is less than 20 degrees, that is 0 to 20 degrees, you just observe, right? So this observation is by putting the spine into the splint. So here you use what is called the scoliosis splint or the scoliosis brace. So here you use the orthosis to mainly prevent the increase in the curvature of the spine. So one such brace which you do use is your Milwaukee brace, and the second one is the Boston brace. So Milwaukee brace is again the cervical, it includes the cervical, thoracic, lumbar orthosis, and Boston is again thoracic and the lumbar orthosis. So this starts right from cervical, thoracic, lumbar orthosis. So for higher curves, whenever the curve is extending in the upper thoracic and the cervical, you go for Milwaukee brace, and below one is you go for your Boston's brace. And Boston's brace is a prefabricated brace which is like a shield. It is enclosed like a shield. So that is the Boston's brace. So in case of scoliosis, you use these two types of brace. So that is the scoliosis brace, the Milwaukee and the Boston's brace. And then you have the von Rosen splint. We already discussed that we use this in case of the DDH, right? And here in this image, they are showing what is supporting the thoracic and the lumbar. So there is the thoracolumbar orthosis, that is your Taylor's brace, right? So that is about the splints, and you have to be thorough of the splints. So we have already discussed the aeroplane splint, the knuckle binder splint, the cock-up splint, and now we have added the spine orthosis, that is your Milwaukee, Boston, and the Taylor's brace, right? So that is about the splints. And next, see, this is the most important and the favorite questions of many examiners. So this is regarding the fracture. So in case of fracture, you see, so here in this X-ray, they're classically showing what type of fracture. So if you identify, this will be the radius and this is your ulna. So there is a fracture in the radius, and if you remember, this will become somewhere around the middle third. So this is the distal, proximal, and the middle. This is somewhere the junction of the distal and the middle radius, right? So distal radius, or somewhat a type of distal radius fracture. And here they have already shown one more arrow, that is there is a disruption, that is there is a disruption of the distal radio-ulnar joint. So there is a distal radius fracture with DRUJ, that is the distal radio-ulnar joint. And now you have to answer this as which type of fracture? The Galeazzi fracture, right? And reverse of this, so whenever there is a proximal ulnar fracture with radial head dislocation or proximal radio-ulnar joint involvement, that is your Monteggia fracture. Please don't confuse. Monteggia is M for medial ulna, right? And whenever there is M for ulna, obviously there is one more bone, that is radius, that is your Galeazzi fracture. So here you answer it as the Galeazzi fracture, right? So this is about the fractures in the forearm bones. Two important fractures. Actually, we can reduce four important ones. So first we have discussed Monteggia. So there will be a radial head dislocation, then there will be a Galeazzi fracture, and you have your Chauffeur's fracture. What is Chauffeur's fracture? The radial styloid fracture, right? And in case of distal radius, you have your Colles fracture, So you everybody are very much familiar with the Colles fracture, right? So this is at the cortico-cancellous junction, and it is an extra articular fracture with a classical displacement, that is the dorsal displacement with supination, impaction, dorsal tilt, dorsal displacement, lateral tilt, and lateral displacement. So that is the definition of the Colles. You have to classically tell that it is at the distal radius cortico-cancellous junction with which is extra articular and with those classical displacements, right? So this displacements will define the fracture. So that is Colles. So reverse of Colles is your Smith's fracture. Smith's fracture is nothing but there will be a ventral tilt or ventral displacement of the distal fragment. So reverse of Colles. So once you are thorough with the Colles, anything reverse of Colles, again an extra articular with the ventral displacement and ventral tilt is Smith's fracture. And there is one more, that is your Barton's fracture. So what is a Barton's fracture? It could be this is mainly an intra-articular fracture. So there will be an intra-articular extension of the fracture, and this could be in dorsal or a volar Barton's, right? So this is of two types. So it could be a dorsal Barton or a volar Barton's fracture. So that is the various epinomes of the fractures around the distal radius. So what is most important for you is always the Monteggia and the Gillespie, right? And then your Schoffer's, that is the radial styloid, your Colles fracture, the classical Colles fracture, and then reverse of Colles, the Smith's fracture, and then your Barton's fracture. So these are the various fractures. And if you remember the Colles, they can even ask the deformity. So that is the dinner fork deformity, which is seen in case of your Colles fracture, and your garden spade deformity in case of your Smith's fracture, right? So this is the extension of the topic, that they can even ask the deformity. And here the Colles will always result in malunion. So this deformity is because of the malunion. So this malunion will occur, so there will be no union, and because the displacement is on the dorsal side, it will result in the classical dinner fork deformity, right? So there will be a dinner fork deformity. And Smith is ventral, so there will be a garden spade deformity. So these are two important questions which might ask in your exam. So that is about the fractures around the radius and the ulna. Right, now let's go into the next question. This is again a trauma. So here there is a 34-year-old patient comes with after an injury. So this is an injury there is present, so there is a trauma. After seeing the x-ray, what is the probable diagnosis? So you have to be thorough in naming the parts of the x-ray. So this is your femur, this is your tibia, this is your fibula, and in the knee joint there is what is called the patella. So here this is very easy, simple question. So directly you will mark this as your patella fracture. But sometimes you have to be careful with the biparietate patellae. So there are always two patella which are present, and this can be confused with the patella fracture. So for this, how to diagnose it? You go for opposite limb x-ray. Opposite limb x-ray, and here opposite limb x-ray, and there is no history of trauma. That is very important. So here there will be no history of any trauma which is given in the exam or which is given in the question. So whenever there is no history of trauma and if still you see two patellae, then you have to always be suspicion of biparietate patellae, right? And you have to confirm by taking the opposite x-ray. And in case of the injury and you have classical swelling, tenderness, pain over the knee joint with the displacement of the patella like this, so this is the classical patella fracture, and there are types, various types where the fracture can occur, right? Patella fracture can be occur as a simple transverse fracture, or it could be a comminuted fracture. So this comminuted fracture is mainly seen in dashboard injuries. We have already discussed the dashboard complex. So in case of dashboard injuries, you see this combination of the patella, and here this is a transverse, and you can see an avulsion fracture in case of patellae, and you can see a pole, upper pole fracture, lower pole fracture. Okay, so these are, and the one more thing is the star shape, that is a stellate fracture. So these are the various types of fracture depending upon the mechanism of injury where the patella can present with. So here, if it is a simple transverse fracture, so how do you deal? So this is the patella and it is divided like this. So there is a fracture like this, right? And how do you treat? The most common modality of the treatment of patella fracture is the tension band wiring. So we go with what is called as a tension band wiring, and here you put this wire. So you join them, reduce the fracture fragments, and you put this tension band wiring in the figure of 8, right? In the figure of 8. So this is the most common treatment which is done in case of patella. So that you have to remember the tension band wiring, where you convert the distraction forces into the compression forces. Why there is a distraction? Because this patella is attached by the quadriceps tendon above and the patella tendon below. So because of this pull of the tendon, so one pole, that is the quadriceps tendon, is pulling the upper pole and this patella tendon is pulling the lower pole. So that is why there will be a no union which is occurring. So because the fracture fragments are pulled apart, now with the tension band wiring you put them together. So whenever there is a movement or whatever the distraction has to be occurred is converted to compression, and then the fracture will unite with the help of the principles of tension band wiring. So that is what you have to remember regarding the patella. So first one is patella fracture is a direct injury and it is a component of the dashboard injury, and this patella fracture can be of various types, and one such important classical type is the transverse, and where you treat with the tension band wiring, right? So that is the question. Let's go to the next one. A 36-year-old has a history of trauma and pain right hip with flexion, abduction and external rotation. So here there is a 36-year-old with history of trauma and there is a pain with flexion, abduction and external rotation, right? So what is the most likely diagnosis? So from our previous slides and previous discussion, we know there is a hip anterior dislocation which presents with this flexion, abduction and external rotation. But if the answer was with the elderly persons and minimal trauma or trivial trauma with abduction and external rotation, you should always put fracture neck of femur or the IT fracture. So because this is a young patient and there is a history of a trauma, that is a forcible or the high velocity trauma with this particular displacements, that is your abduction and the external rotation, so it is likely to be the hip anterior dislocation, right? So we have discussed much about the hip dislocation, right? So this favor will be more seen in case of your anterior dislocation. So now the next one, here the 59-year-old female. So here there is a female complaining of bilateral knee pain. The pain increases while going up and down. The X-ray shows bilateral reduced joint space. So when I have discussed about the joints and the X-ray findings, that is, we have two types of joints which you have to always take care. That is, one is the degenerative one and the next important one is the inflammatory. There are various such as crystal deposition, the other seronegative arthritis, but the most one which you have at your level is the osteo and the inflammatory, that is the degenerative and the inflammatory. So whenever somebody has to tell you about inflammatory disease, so that is because of the antigen antibody reactions, right? So there are complexes which are formed in inflammation. So this inflammation of these antibodies which are formed, they will go and damage the synovium. So these damage of the synovium will produce inflammatory cells. There is what is called as pannus, and this pannus will destroy the joint. So they will destroy the cartilage, they will eat away the bone and they will spoil your joint, right? So that is how the inflammatory arthritis sets in. So when somebody uses the terms bilateral knee pain, bilateral reduced joint space, you can blindly go with the inflammatory condition. So here in case of inflammation, again we have ankylosing spondylitis and a rheumatoid arthritis. But ankylosing spondylitis, if you remember, it is mainly the axial skeleton which is involved, and as this question is involving females and knee, the most likely answer is rheumatoid arthritis, because again ankylosing spondylitis is mainly seen in males, and it is mainly the spine which is the complaining segment of the ankylosing spondylitis. And hemophilic arthropathy could be, but again this is seen in case of males, right? So here this is a classical of the pain increases while going up and down, that is again the activity. So there is an increase in activity, increase in pain, and bilateral reduced joint space is rheumatoid arthritis. In case of osteoarthritis, it is never bilateral. It could be bilateral, but it is not similar in structure. Here in rheumatoid it is bilaterally symmetrical. So these words of bilateral you have to put in mind, and always first put inflammation as your first option, right? So that is about the question number 22. So now the next one is child with a widening of bone as this x-ray. So here immediate catch of us is the child, right? And there is a widening of the bone on the x-ray. What is the given condition? So this is again an important bit. This is talking about the rickets. So rickets is what? Rickets is nothing but there is a demineralization of the bone, or simply it could be a defective mineralization. So here, because of the absence of what important vitamin, so there is absence of vitamin D. So this vitamin D is now considered as the hormone, and it is supposed to be the most important vital element which is important for absorption of calcium. So this calcium is what is deposited in the bone, and this calcium and phosphorus will give the strength to the bone. So because of this defective mineralization, the bones become weak, and now because of the weak bones they go into deformities. So classically in the rickets, the patients presents with deformities, right? So the most important thing in case of rickets is the deformity. So what are those various deformities? So first you see genu varus, then you can also see genu valgum, and then you can also see your wind swept deformity, right, in case of children, right? And then in case of your wrist joint, you see there will be a swelling and there will be a widening. All this because of the growth plate changes. Now your osteoblast will form the cells, and now these osteoblasts are calcified with calcium and phosphorus. That is how bone is formed, right? The osteogenesis. And now because of the increase in the cells and there is a decrease in the mineralization, there will be widening of the spaces, widening of the growth plates. So here classically you see all the pathology which is occurring around the growth plate. So you take the x-ray which is showing the growth plate, and you can see various signs, that is your cupping, fraying and splaying. So all this you see around the growth plate, and classically you see in the radius and ulna. So you see a cup shaped here, and this is called the fraying, right? So this is the cup shaped fraying and splaying which you see, and that too in case of a child is always a diagnosis which is leading us to rickets. So this is the rickets, right? So rickets is one of the important question, again the metabolic disorders where because of defective vitamin D, so there is decrease in the vitamin D supplementation to the children, and then this vitamin D is very very important for the calcium metabolism. So here the calcium metabolism is mainly the 90%, 99% of the calcium is present in the bone, right? So this bone becomes weak. So this weakness is seen mainly around the growth plate. So there is a defective mineralization around the growth plate which is seen classically as cupping, fraying and splaying. So here the patient presents with widening of the and the pains over the bone, and with the deformities that we have already discussed, right? So that is about the rickets. And in case of scurvy, so what is this scurvy? So scurvy is defective collagen. So scurvy is the defective Collagen, that is where the bone structure itself is weak. So there is a matrix of the bone. So this matrix of the bone becomes weak. So whenever the bone becomes weak, this matrix, this will become brittle. Right, the bone now becomes brittle. And why there is a defective collagen? Because vitamin C is involving for cross linking of the chains which are present in the collagen. So now this cross linking will be defective, then the collagen is defective, and hence the bones become weak here, which will present as the scurvy. So scurvy answered, you have to always search for vitamin C. Rickets, vitamin D. That is how you remember, right? Next, identify the given image. So is this a scoliosis, a disc prolapse, or a torticollis? So what is a torticollis? It is called the Wryneck. So there will be a contracture of the sternocleidomastoid muscle, and this will cause the tilting of the head. Right, if you remember, the sternocleidomastoid starts from the mastoid and attached to the clavicle. So whenever there is a shortening or the contracture, there will be pulling of the neck towards that side because of this contracture or the shortening of the sternocleidomastoid. So that is the torticollis. So torticollis can be a congenital or a acquired torticollis. That is the Wryneck, which is here, it is not seen. So the head is straight here, right? So it is not torticollis. Now next, scoliosis. Scoliosis, again the sideward curvature of the spine, right? And usually here the spine is straight and I don't see any curvatures, right? And then disc prolapse. So you cannot just see the patient from the back and tell it is a disc prolapse. You need to get an MRI to tell what is a disc prolapse. But what you see on this image is there is a scapula which is present here, and this is the scapula. So there is somewhat upward migration of one scapula, and you see the low set hair, right? Low set hair, and there is a short neck. So these two go in favor of your Klippel-Feil syndrome. So Klippel-Feil syndrome, you have low set hair, you have short neck, and you have fused vertebrae. So these are the congenital anomalies around the cervical vertebrae. So whenever there is a fusion of the cervical vertebrae, so there is a division is failure. So there is a failure in the dividing or division of the cervical vertebrae, and two vertebrae gets fused, and now they present with the low set hair. So usually the hair should start somewhere near the level of the ear, like below the ear level is your low set hair, and then you see with short neck and some deformity with the scapula. Right, so some deformity with the scapula, this goes in favor of your Klippel-Feil syndrome, right? So what is torticollis? Torticollis is, again, I've already discussed, that is Wryneck, and scoliosis we have discussed that there will be a bending. So there will be a deformity which you see, that is a sideward bending or sideward twist of the spine, right? So this is the scoliosis. Here in this image you see there is a low set ear and there is a short neck, and this is called the Klippel-Feil syndrome. Okay, and what is Springel's deformity? Springel's deformity. Springel's deformity is nothing but failure of descent of the scapula. Failure of descent of the scapula, hence the scapula will be elevated and prominent, right? And it will be a shorter one, short scapula, right? Short, rounded with the and with upper border being prominent, that is the medial border becoming the prominent, and there is a failure of this descent, that is called the Springel's deformity. Sometimes this deformity can be associated with your Klippel-Feil syndrome. So that is the Klippel-Feil syndrome. So now because we have the sessions on the 2 days, right? Today is the first session, that is part 1, and tomorrow we have part 2. So this would be the last question. We have come to the end of this part 1 or part A of the session, and the next questions will continue tomorrow. So now let us answer the last one. So identify the labeled structure in the X-ray. So here again, this could be in anatomy or the radiology or the orthopedics, right? So this is one side of that integrated question. So here you have to identify the parts of the X-ray. So here let us make it easy. So first this is the radius, and this is your ulna, and this is your humerus. So this is your distal humerus, and this is your olecranon fossa. So you know olecranon, there is a trochlea which is getting into the olecranon, and here this is the lateral and this is the medial, right? And you know the distal radius, the distal humerus will have epicondyles. So this will be a lateral epicondyle, and this will be a medial epicondyle. So what is a medial epicondyle and a lateral epicondyle? These are the most prominent parts. When you touch over the distal humerus, or when you are walking over the distal humerus from top to bottom, you will feel one prominent part on the condyle region. So this prominent over the condyle is your epicondyle. So this on the lateral aspect is the lateral one, and the medial aspect is the medial one. And then here what he has asked us, so this is the arrow mark, right? So on the lateral side, what you see, the capitulum, right? So radial head is already there. This is not the radial head, and now this is the trochlea. So this is not trochlea, and lateral epicondyle. So the lateral epicondyle is one which is very prominent. Here you see what is called the capitulum, because the radial head will unite with this capitulum. So it will form the joint with this capitulum. So there is a connection between the radial head and the capitulum, which is called the radiocapitellar joint. Right, radiocapitellar joint. So this is the radial head with the capitulum. So the answer would be the capitulum. So likewise, you have the various x-rays which you have to identify. So there we have learned the foot x-ray, we have learned the dorsal bones, and then now here we have completed the elbow x-ray. So now let us stop the session here. So tomorrow we'll again continue with the questions. So see you back tomorrow at again 5 p.m. right? Thank you for the